this episode on the podcast of Equality, Diversity, Inclusion in Health Psychology. I am joined by Professor Jane Ogden, who will be sharing her thoughts on how we embed EDI in both our practice and perhaps some of our curriculum in terms of research and also teaching. So welcome, Jane. Thanks so much for your time. How are you?
You're welcome.
My first questions was going to be like, let's do some introductions just for the audience. I think you're episode number 9. So we've had lots of different guests, different perspectives, and we normally get an overview about who they are and what work they do. So tell us a bit about yourself, Jane.
Okay. Well, I've been in health psychology for, I suppose, 35 years now, which is a long time. I'm currently a professor at the University of Surrey, where I teach health psychology to a whole range of people, from psychology students, nutrition, dietetic students. We've got a vet school here, so I teach vet students, and we've also got a kind of burgeoning medical school. So I've taught physician associates and other kind of medical type nursing students as well. And I do research on eating behaviour, weight management, obesity, but also language and communication, symptom perception I've been really interested in, and also done work on aspects of women's health over the years, including abortion or miscarriage or pregnancy, or women's specific health conditions like PCOS. So I've been always interested in those kind of aspects. I've also been quite keen on doing kind of media work, which I've loved, I suppose, over my career. So I've done various different TV programs, radio programs, written for magazines, aspects of the media, do quite a lot of radio, that kind of thing, all of which I've really, really enjoyed. So yeah, I guess I'm a kind of all-rounder health psychologist. Before I was at Surrey, I taught in a medical school for 13 years, which I loved. We ran an intercalated psychology degree for medical students in their 3rd year, which was great fun. We had a master's in health psychology, but I also just taught, huge lecture theatres full of medical students, and taught them aspects of psychology related to bits of their medical degrees. And then prior to that, I had my first lectureship, which was at Middlesex Poly, as it was. And it was at Middlesex, when I was there, I was asked to run a module in health psychology. So that was in 1990, something like that. I was asked to run a module in health psychology, which I did, set it up from scratch. And that's when I sort of discovered what health psychology was, really. I didn't really know what it was before then. I'm not sure it massively existed before then. But I'd done a PhD in eating behaviour and a degree, believe it or not, in neurobiology rather than in psychology. So I think probably 1990, when I set up a module in health psychology, I then thought, OK, that would be my home. And I didn't really have a home until that point. So I sort of decided, oh, OK, I'll become a health psychologist, and started to go to the health psychology conferences. Then I wrote my textbook, first edition in 1996 in health psychology. So I suppose I invented myself as a health psychologist at that point.
Thank you so much for sharing that. I feel there's so many different podcasts we can do with so many different angles, isn't it? Like, I didn't know, especially what you said about integrated course with the medical students, like with psychology. How did that work out? You said it was quite great fun, but
it's lovely. I mean, what medical students often do, they don't do them quite as much now because the medical curriculum's changed, but they do 2 years preclinical training, and then in their 3rd year they can opt to do an intercalated degree. And they can do it in whatever they like. They can do it in biosciences, or they can do it in physics or maths, or they can do it in psychology, or they can do it in literature or whatever. They can pick a subject as long as the university offers it and do an intercalated degree in it. So when I was at Guy's, we just ran an intercalated degree in psychology. So they did a compressed psychology degree in 1 year. So we got the medical students who were interested in psychology. Some of them weren't thinking about going into psychiatry. Some of them wanted a break from medicine. Some of them had done psychology A-level, but they just wanted something different, really. So we taught them all different bits of psychology, not just health psychology. We did developmental psychology, some cognitive psychology, and then we did all the sort of mainstream health psychology stuff as well. And they were good fun. They were very bright students. They picked it up remarkably quickly. They were very interactive, and yeah, it was a nice thing to do. And being part of that kind of medical world, they went off and became GPs and, whatever they did in their careers. So out there. There are lots of medical students that I taught for those 13 years, which is a nice thing to do.
It's an example of like inclusiveness, like the way psychology is, it's open to everybody. It's not just we're on our own here. We have to talk to our partners and our people who do the health work, especially in health psychology. Is that something that you can see?
I mean, I think the thing about being a psychologist for me has always been about curiosity. And I think, being a psychologist, being an academic psychologist, probably also being a clinician, which I'm not, it's sort of legitimized sanctioned nosiness. So, you actually are just interested in how people tick, what makes people work. And that's everybody. So, for me, finding out about people's lives, whether they're a bit like me or a bit not like me, has always just been really, really interesting. So, I do qualitative and quantitative research, but that enables me to sort of delve into people's ways of thinking, how they sense make about the world, their experiences, their childhoods, their families, their culture, their background, and that has to be inclusive because that's where that curiosity comes from, really. So from a research perspective, it's about that huge, rich variety that's out there in the world. But then if you're working in a medical school or you're working in a healthcare setting, then you're dealing with patients and you're dealing with healthcare professionals that come from all sorts of backgrounds. So, it's about always just being interested in difference and finding out about how people tick and how fabulous that is that we're allowed to have access to that. I mean, that's how I've always felt. I've always felt incredibly privileged that my students will come from different lives and share their lives with me, and that I have little windows into all sorts of different beliefs and cultures and backgrounds and experiences. And then when I'm doing my research, I can just, because an ethics committee said it's all right for me, I can go and ask people questions and find out how they live their lives. So it feels essentially all very inclusive, really.
Yeah, and do you find as like someone who's doing the work, like a practitioner, researcher, or communicator, you have to be like cognitively flexible, if you like, because people come from different parts of the upbringing and how they frame a reference, and so you as on the other side have to work with that person or listen to that person, and you have to leave your own biases or be aware of your bias and just listen to this person. Do you find that cognitive flexibility?
I think that for me it's always been about acknowledging my biases rather than pretending I don't have them. I'm white, I'm a woman, I'm straight, I'm from, I was born in Essex, so I'm a sort of North London Essex girl in lots of ways. My family are all from Manchester, so I always feel I have a very strong identity with the kind of north of England, really. So I kind of feel that that's where I'm positioned. And with that comes a whole load of prejudice about people that aren't like that. And I often, when I'm dealing with students, or I'm kind of doing research or dealing with other kind of healthcare professionals or whatever world I'm in, I'm often kind of just surprised, and then I have to do a sort of little, it's like a kind of bit of cognitive work in a way to think, oh, I'm surprised people are different, and then I have to go from, oh, that's odd, to, oh, that's interesting, and do a kind of, a take to think, oh, okay, that tells me something about myself. The very fact that I was surprised about that tells me about how I think, and I'm always really interested in that. I mean, maybe it's a bit, introspective or whatever, but you find out by talking to other people how you feel and what you consider to be the normal or the acceptable position to be from, because of my life, my childhood, my family, my children, my education, or whatever. So a little light bulb often goes on, and I go, oh, okay, and then I instantly just want to find out more, really. So I suppose that is that cognitive flexibility. I guess it is, being constantly aware of those kind of differences, I suppose, or challenges that you face in your life.
Yeah, and then you have to adapt, isn't it? You have to adapt because you have to speak to people where they are, isn't it? Their understanding.
Yeah.
To be able to really connect with them and really actively listen.
Yeah. Well, you do both, don't you? I think you find difference, and then also you just find common ground. So you suddenly find that you've got, I don't know, however different you might feel, you've got things in common. Of course you have. when I was at a workshop last week in Manchester on female genital mutilation, and they asked me along to come and give a talk about kind of the psychology of women's health and women's bodies, but from a much kind of broader perspective. And I know very little about FGM and have never worked in FGM. And there were people there who were absolute experts in FGM and talking about research on it, but also talking about supporting other people who've had FGM. But then also there were survivor stories who've had FGM. And you think this is miles away from my experience. But then you talk to people and you find out the differences. But then, you know, but before you know it, you're talking about, you know, being a mum or having children or giving a talk at a conference, or, you know, what's Manchester like, or where have you been? And you find common ground as well, really. So it kind of works both ways, really, I think.
Yeah, I find that it's building relationships, rapport, trust is a big thing. When we are connecting with other people, especially trying to understand them, like how do we make it much more accessible? How do we help? How do we? I think that's the type of psychologist, like that's the bit that I think I'm training towards to, or trying to become, to be that ethical person.
Yeah.
And by looking out and observing and learning from the others, like how do they do it? So you touched upon something that was like early in your introduction around eating behaviour. You have a special interest in that, and the reason why I mentioned that is because eating is a universal habit, right? It's a universal behaviour, whichever you want to look at it, and we all relate to it. And I think food, obviously, is a universal language. We have different cuisines, and it's one of the things that we sometimes can all agree on, like taste. We have our preferences, but why did you choose eating behaviour, eating in general, like as a topic of interest? Yeah.
I mean, it goes back a long way, really. I mean, I went to the University of Sussex, and I did a strange old degree, really, which was a kind of mishmash of different kind of modules. But one of the modules I did was on sexuality and literature, which is very much around feminism. And I very much identified as a feminist at the time. Well, I still do. And that module was very much about kind of women in literature and women's bodies and things which influence women. So I guess, you know, that was the kind of the beginning of it. Fat is a Feminist Issue by Susie Orbach came out at about that time. And so the notion of women's bodies and food and dieting was being kind of politicised, I suppose. And so I was interested in that. I came from a family of people who were always on diets, talking about food being good or bad or demonized or not demonized, but I was quite interested in the language of food. And then the option came up to do a PhD with Jane Wardle at the Institute of Psychiatry, and she was doing stuff on eating behaviour and dieting. And it wasn't a particularly feminist PhD, or it didn't kind of come from that background, but it certainly sort of fitted in to that kind of, you know, general area of things that I was interested in. And it was a very experimental PhD. And I ran some studies and collected some data, but the broader context of it was about the kind of politics of understanding how women change their bodies to fit in society, and then how food plays itself out in those dynamics. And the Institute had a big eating disorders unit at that time. So, you know, we were rubbing up against people who were working in eating disorders as well. So that was very much around how food can become quite problematic for people. So, you know, you say it's a universal language, but it's a very complicated universal language, which can mean so many things to so many different people. And that's the bit I've always been interested in. I think as time's gone on, is I'm interested in how food is used in relationships, in culture, how it plays out in those kind of dynamics. And then why the body can become so problematic for people, I suppose. So, you know, I'm a sort of psychologist in the here and now with the individual, but I've always liked that kind of bigger picture around the outside.
But this is what I mean by diversity, isn't it? There's diverse ways of looking at it, different ways. And in your from what you've have gathered over the years, like in this area around how people are different, why do you think it matters to understand this? Like from your perspective, why do you think we should understand this as public health practitioners or health psychologists? Why should we care, and why should it matter, do you think?
That people are different.
Or the food experiences are different, or the eating behaviour is different.
Well, everything's different, isn't it? And I guess, you know, what we were always trying to do is to change things and make them better. And we're often falling into a kind of one size fits all approach. You know, so if we could have, you know, if we had CBT, or we had counselling, or we had systemic therapy, or we had a behaviour change intervention, or we have a leaflet, you know, or we have a website, that would help people. And the people bit becomes this uncomplicated, universal person somehow that we think that we can target and change what we do for them, and then they will change what they do. But, you know, I think there's so much variability. You know, there's that person who's hugely varied, and we need to target what that person wants. But there's us as interventionists who vary, and then there's this fabulous magical space in the space between us, which is a, you know, a concoction and more than the sum of the parts. So, you know, you stick two people in a room, or you stick a person interacting with an intervention, the space between those two things creates this extra dynamic, which is incredibly hard to measure or to identify. And so there's huge variability. So the idea that we can invent a thing that will work for everybody is just wrong. You know, people vary, and we vary, and people vary not only in themselves, but they vary from time to time or situation to situation. So, and that's the wonderful thing about human beings, isn't it? It's the kind of, you know, the huge diversity that's out there. So we need to try and understand that. And I mean, researchers, we've neglected that, you know, since the beginning of time. So psychology's tended to be done on psychology students. A lot of psychology has been done on psychology students, and psychology students, you know, were pretty much white middle class girls, who then became, you know, grew up to become women. But mostly in that window of what studies have been done on, it's been done on that population. And the idea that in any way that tells us about other populations is just kind of naive. And clinical research is done on populations who choose to take part in clinical studies. And so those are the people that come and seek help, the people who end up in clinics, the people who consent to take part in studies, and then the people who do take part in studies. You know, and if you think of the, you know, the response bias along all those chains of reaction, there's a hell of a lot of people who don't seek help in the first place. And then there are people who seek help but don't go to the clinic or don't turn up. And then there's the people who drop out of the studies. So what we've got is research done on a very rarefied set of the population. And the idea that the results from those studies would relate to other populations is also really problematic. So we've got a very narrow, you know, narrow data base to work from, really, in terms of what works for whom.
Yeah, no, that's really insightful and very useful for our listeners to pay attention to that, because yeah, where it does our intervention, who is it based off? When we're looking at saying we need to use evidence-based, you know, literature, well, who is it that's taking part in these things? And I think that's really important to consider, because they're looking for the solutions of like how they solve these problems. We, as the on this side of the researchers, if you like, or interventionists, we have to be careful about this. And my other question was going to be, I think you've kind of answered it, which is how hard is it to do this approach where you don't have, you know, a one size fit model, but to do this tailoring, how hard is that? Just thinking about the future or the current trainees in mind.
Well, I mean, it's always about, you know, I suppose interventions are always about reach and effect size, aren't they? So, you know, you can have light touch interventions, which are cheap, done at perhaps at a kind of public level, public intervention level, public health level, and they can be quite cheap and they can have huge reach, but tiny effect sizes, and they won't be tailored to the needs of the individual. They won't be very effective, but because they've got such massive reach, some people might change because of those. Or you can have highly intensive interventions which were quite costly, but can be tailored much more to the needs of the individual. And in a way, any kind of intervention is always a kind of push-pull between those two extremes, isn't it? And it's difficult, it's expensive, we don't have the data, we don't know what we're doing to tailor it to the person. But then if we do these blanket approaches, they won't work for that many people. I guess we just got to make a choice, really. But we don't even have the data to know what those people will need. I mean, I suppose what I've always been interested in is when you take population, that population belongs to lots of different categories, don't they? So I'm white, I'm a woman, I'm 57, I'm a mum, I've got 2 children, I live in Guildford. I belong to lots of demographics. You don't. You're belonging to different demographics. But if you're targeting me, do you give me the intervention suitable for a woman, or do you give me the intervention suitable for a 57-year-old, or for a mum, or for someone living in Guildford? I belong to, even I'm complicated because I belong to lots and lots of different demographics. And that's why it becomes so complicated. So you can't even say I'll tailor it to you, because it's like, well, which bit of me?
Absolutely. Yeah.
I've got multiple identities, and am I in this study as one of those many things that I then occupy? So that's why it's so difficult to tailor it to the individual, really.
I think it's such a useful answer. I think it will reassure some of our listeners. Like, we know it's not easy. We know it's more than one question. Like I said, different demographics, different identities.
Yeah.
So, as a principal, then what would you advise, like, for them to consider if they're designing, say, something like an intervention, say around eating, and they want to reduce, I don't know, say, or they want to improve healthy eating in a certain part of the population or certain group, what fundamental things they should consider when considering definitely inclusivity, but also diversity? What should they consider?
Well, get to know your target population. I think that's the first thing. Really decide who it is that you want to kind of approach, and who are they, and go back to them and talk to them. I mean, I've done loads of work on eating behaviour, and I go on about, I'm a great believer in cooking from scratch and sitting at a table and eating with your family, and not eating in front of the TV. And then you talk to people, and some people don't have a table and they don't have a cooker, and they couldn't all sit round a space to eat together. And you think, God, I'm so out of touch. I'm basing it on my own experiences. So if I want to develop an intervention for a population, I need to find out how their lives are, and not base it upon my own assumptions as to how people's lives are being led, I suppose. So yeah, first of all, find out who your population is. But then also, I don't think even within that there's a one size fits all. So I think you have to be, if you're doing an intervention, you can't just say, this one, I'm going to try this one will work. The best approach really is to have a kind of splattergun approach and think, we've got a toolkit of 15 things that might work. Let's try them out in that population with different people, and then be prepared to say they didn't work, and then try the next one, and then the next one, or create an intervention which includes lots of different things just in case, because the evidence base isn't there to say this intervention will work for this population. The evidence is there to say it might work for some of this population, but it might not. So let's try something else, and then let's try something else. But we don't have the evidence to be able to target precisely matching it on to one really. It's just not there.
I think it's such a relevant topic, and thanks for sharing that. With the cost of living crisis, we know that how people's budgets on food are limited, and they are pushing the absolute limits, if you like, of like how to eat healthy, or how to even have nutritious food, is it? That's why I think it's very important to understand the diverse experience around this area, because we've got so many different challenges. I don't know what your thoughts are on that.
Oh, hugely different. I mean, different in terms of culture. I mean, food is so related to social class and to culture and to childhood, and all the learning that goes on in from the moment that we're born, if not even slightly before, in terms of what food preferences we have, and the meaning of food and how food functions within families. So if you're trying to help someone to change and become a healthy eater, if you're suggesting that they cook from scratch or eat bean sprouts, or eat whatever it is that is so alien to how they eat, they're just not going to do it. So you need to find out what food means to them and how they can eat, and then find out ways of making small changes, really. But we're not going to have radical changes in people's habits, because that's not the way it works. People will just make very small changes, and that will be based upon how they've been eating, for all of their life up until the moment that they come to you. So you can recommend eat more fruit and vegetables, but if people don't eat fruit and vegetables at all,
people like me,
you have to eat You must eat fruit and vegetables.
Now and again, but it's not like a massive thing. So in our sort of like we have a lot of like and we are trying to recipe eat more healthily, but there seems to be like more carbs and meat. So we have like curry and rice. We're trying to control our portion size on the rice because we have loads because of economic reasons, because it fills us up a lot more quicker than the meat.
Yeah.
So it's cheaper to eat more rice with a bit of curry. But the ideal is to have more, have a bit of balance rather than having 90% of carbs, white rice, with like 5% curry, if you like. Because it makes you feel. And we do it as a point of like when it comes to food, as I think a stress response, stress response, if you like, because we live it. Most of our families and cousins, and we work in the nighttime economy, and so therefore we use a lot of energy, if you like, and we have a lot of stress socioeconomically. So we use food as a way to kind of like feel good about ourselves or to interact with others. But we have the rice, and then we have more so my background is like British Bangladeshi, and we are prone to more type 2 diabetes. Because
But when you cook your curry with your meat, do you not have vegetables in the curry? Onions and peppers. And,
yes, I think cucumbers. We've got like not cucumbers, right? The pumpkins. It's quite popular. Potato. We do have peppers. That's quite common. Tomato. I suppose. I think when you look at the plates, when you ever in this house, we look at the plates. Like a lot of it is literally most of it's like full of rice, the white starch, and you get the other bits, and then we typically have in most households. I shouldn't say most households, generalize, but we have them like twice a day. That meal, so we have about 2 o'clock, if you like, 1 to 2 o'clock. Then we have it again about 8 to 9. But it's like when there's rice available, we have about 3 or 4 curries, not just one. So then you have to get the rice like 3 or 4 times to taste everything. It's not something that I do. I've come out of, but I see it happening. And like, if you bring up fruit and veg to these people, I would just give you that whole look and say, "How dare you eat some of my food?" So it's a social interaction. That's what I mean about food. I can talk about food forever, but
it's also it's cultural meaning, isn't it? Cultural pride. It's your identity. It's who you are. No, absolutely. You try and change it. You're up against an awful lot of history, personal history, but also just generational history as well. That's going back. No, and it's very, very difficult to change. And it's difficult to change. Yeah, sorry, go on.
No, sorry.
No, I was going to say it's difficult to try and change without ending up as a kind of being paternalistic, I suppose. I mean, particularly within the area of nutrition, because the evidence on nutrition is always quite problematic anyway as to what is good and what is a healthy diet. So if you come in with your ideas, you've got to be quite careful that you're not then negating someone else's own ideas about what's healthy, really, as well. So it's got to be done in a kind of respectful way, I think, which is also quite difficult. But then again, the evidence for that, the evidence on what's a healthy diet is also problematic evidence. So if you want to change, this is why I struggle. This is why I'm not a practitioner. It's because to be a practitioner, you've got to know how to change somebody, and you've got to know what you want to change them into. And I've never felt very comfortable in either trying to change somebody or knowing what they should be at the end of that process, because we don't really know what a good anything is. Probably apart from not smoking, which I feel quite strongly is probably a fairly good thing to not do. That's quite black and white. Everything else is all a bit murky and a bit kind of grey and muddled anyway, really. We should do more exercise. That's probably good. And we shouldn't smoke. That's good. But, whether we should really eat brown rice rather than white rice, we probably should. But,
Yeah. I think that's a really good point you made around earlier. So you said to me that I probably don't. I said I don't have fruit and veg. So you probably don't really have it. And I thought actually I do. And so it's that bit, isn't it? That sometimes we think that we're not doing those things and we just dismiss it and we try to put it under there, and therefore we're not able to reinforce it. Isn't it? Yeah. So it's interesting. Even in this conversation, you just said something, and I basically thought, hang on. Actually, you are right. Yeah, I do. In my other places, I should have dismissed that.
Yeah, that's right. But also that's because we think of vegetables as being the thing on the side. So, you know, you have your curry, you have your rice. I'm not having any vegetables with it. But
Yeah.
that's a very kind of Western diet, isn't it? That the vegetables are on the side and therefore you don't have to have them. But in other diets, the vegetables aren't even considered a separate thing. They're just all mixed up anyway. So they are in there. So you're better than you think you are.
I think that's very important, because I think people do feel like, when it comes to like stigmatized, that they're not having enough.
Yeah.
And then they just think, you know what, I'm not going to bother with the fruit and veg. I'm just going to do what I do because it's too stressful to think about it.
Yeah.
I'm not, too much to conform. So we need to identify the good things we are doing.
Yeah.
And not dismiss that, isn't it? Encourage it rather than try to go for like a this is the only way you're going to have veg, and this is the only way you'll have fruit.
Yeah. And as an essence of behaviour change, we in this sort of world of carrots and sticks, we don't respond very well to criticism or negativity at all, do we? We just want to be rewarded really and praised. So you're only going to change someone's behaviour if you're really positive about what they're doing now anyway, and you can build a rapport, and then you can start finding things that they can change that then you can be positive about. But sort of, I suppose Skinner was right, really. It's all positive reinforcement, and that's what we need to be doing. So I can't come to you and say, you rubbish, you're not eating enough vegetables. I need to say, look, brilliant. Actually, you're doing really well because you're doing this, this, and this, and then you'll feel better about yourself, and then maybe you'll change eventually.
It's not as threatening, when you do it like that, isn't it? It's so evolutionary. Like if you think if it's a threat, our system's got the defense mode, we just shut down and just walk away.
No, that's right. As soon as you feel criticized or threatened, you put your fingers in your ears, don't you? I mean, that's what I always teach my students, is that people naturally put their fingers in their ears and go, blah, 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 I can't hear you. And our job, if we're going to do interventions, is to get people's fingers out their ears. I mean, that's the first step, isn't it? To actually get people to listen to you. And however loud you shout at anybody, they've got the fingers in their ears, nothing's going to go in. So you need to build that rapport and that relationship to get the fingers out the ears in the first place.
And that's the tricky bit, isn't it? It's
almost like absolutely.
Why do you think people do that? Is it because they don't know what to do and they don't want to come across as if they don't know? Is it because they don't want to say the wrong thing? So do you know what? I just won't interact. What do you think that is?
I think we don't like being wrong. We don't like being criticised. We don't like negativity. We don't want to feel bad about ourselves. We want to have a nice life. We want people to like us. So as soon as anything comes across that's not like that, we think, we get defensive and we switch off and we just stop listening. Or we know what we think, if there's a power dynamic, we think we know what's right anyway. So, why would we listen to somebody? Because they've got nothing to say to us that could be of any possible interest, really. But we often spend a lot of our lives with our fingers in our ears, not listening to anything, don't we? Go through life like that quite happily, really.
And do you think that transposes into like us professionals? Like, can we do that? Like, so we got the, patient or public or client, whichever, they probably do something. But as practitioners, something about current health psychologists and training health psychologists, is there a danger that we do that? Like, we think that we know everything and this is the way you're going to be, and this, we just want to talk to, even if we don't want to talk to our colleagues, let alone, the patient.
Yeah, I think it's across the world, isn't it? It's across professional world, practitioner world, research world, teaching world, is that we're not open to discussion really, or debate, or listening to other people really, in lots of ways. I mean, in my world as an academic or as a researcher, there's so much pressure on individual careers, building a reputation. Everybody wants to be director of the unit or to have their own kind of identity out there as having some sort of, seniority or whatever. And because we're building reputations and trying to make ourselves famous, then we have to be right. You've got to be right. And you can't answer a question with, oh, I'm not really sure, or I don't know, or it's all a bit muddled. So we have to be right. And then in the practitioner field, we're sitting with clients. And so there's an automatic power dynamic there, whoever that client is, are we, helping public health or helping an individual or whatever we're doing. But we're sat with clients and they turn to us and they ask us a question and we have to know the answer. So again, we're putting ourselves in the position of knowing what that answer is, and that creates a sort of sense of certainty. So academic and practitioner careers and teaching as well push you into this role of being the one who knows things and the one who has the answers, and that's how you get on, and that feels safe. And so it becomes really hard to say, oh, I don't know, not really thought about that, or isn't that complicated or something. So we stop listening, I think, really. And then we start pretending that we know the answers to everything. And that's the dangerous thing. I mean, what I've loved is the older I've got, and the once I became a professor, it was much easier to then not know things. And that was a lovely thing to do. It was I felt much more confident and be able to say, actually, I don't know. I have no idea what you're talking about. Don't understand. It's complicated. And I could do that because I felt, I was older or whatever. Whereas I think a lot of people feel that they have to think they know everything or have black and white answers to things, which is a shame, really.
Well, that was going to be my next question, like around what would you say that you've noticed the changes in your time in health psychology? Has it, I assume it's improving all the time and we're becoming much more knowledgeable in terms of inclusivity about different groups, different populations? Have you noticed a change? Have you noticed that other people are starting to look at different groups in different ways? Is that thing happening? Or is there still got a lot of work to do? Or is actually nothing happening from your perspective, from what you've observed?
Gosh, I mean, I think things come in waves, don't they? I mean, there's theories which come and go, there's models which come and go, perspectives come and go, methodologies that come and go. When I started off, not many people did qualitative research. Lots of people do qualitative research now. So that's probably come with a slightly shift in perspective, that people are more open to difference or open to listening to what other people think because they're trying to do qualitative research. But theoretical frameworks, there was a time when everything was a self-regulatory model. There was a time when everything was a theory of planned behaviour, or everything was cognitive adaptation theory. And, now at the moment, everything is behaviour change wheel or the combi. But these are fads that will kind of come and go, or they're moments of time. So I think that has changed. In terms of kind of, I suppose, diversity, I think we're all maybe trying to be, more aware and more aware of diversity, or to be more kind of inclusive. So, research was always male versus female. That's being diluted a little bit. Lots of research on sexuality was, gay versus straight. That's, again, being kind of challenged a little bit. There's definitely a sense of ethnicity being something that we need to be much more aware of, because so much research was done on weird populations, and I think people are beginning to challenge that. So I think it's slowly happening. In my recent textbook, I kind of I looked at it through a very kind of EDI lens this time and thought, right, gosh, come on, Jane, sort this out. You need to be a kind of aware of all these things. And it's quite a hard thing to do, because historically, gender has been dichotomized. And so research has been male versus female. So then you think, oh, what do I do with that historical research to bring it into a modern world where we can talk about it being more fluid? And ethnicity wasn't mentioned in lots of research. So how do I bring ethnicity in to make sure that it's kind of centre stage? And the same with sexuality. So you suddenly see your own discipline through a different lens and think, gosh, it's a bit outdated, so we've got to drag it in to the modern world, really. And then you feel a bit tokenistic by doing it, but it still needs to be done, so sort of do your best, really.
Well, no, that was good. That which leads me on to the other question, which is, you publish lots of materials, and you say you do a lot of work, like you enjoy working in the media and different media forms, because I think it's important that we communicate our stuff, if you like, to the public, and we're also members of the public. So I think it's really good. And the latest book that you've got, you said you've got an EDI sort of lens on it. How was that process for you? Was that an easy thing to do? Was it difficult? Just thinking about other people who might be thinking about going through that similar path. And so they feel like, oh, okay, I'm going through the same thing.
Yeah.
With that in mind, was it an easy thing to do?
It's not an easy thing to do because we're of our generation, aren't we? So, you know, a lot of the ways the world is thinking now is different to how the world was thinking 30 years ago when I first wrote my first book, I guess. But, you know, fortunate for me, I'm a mum, so I've got a 23-year-old and a 21-year-old who are very much in the modern world. And also I spend my life sitting in my office with 21-year-olds. That's what I do.
Yeah.
You know, who are as they are in the modern world. So, you know, I'm getting older, and as you get older, you can't help but become slightly out of touch. But, you know, the job means you're in the thick of that world, really. So, you know, my students are what they are. I mean, that's the bizarre thing about being an academic is when I first sat here, I was 24, you know, and they were 21. And now I'm sitting here and I'm 57 and they're still 21. And I've been doing that dynamic forever. So it's hard. It's an effort to put the EDI lens on, but I've been helped along the way by my children and by the hundreds and hundreds of students that I get to know every year who teach me to be aware of how I think and challenge me, I think. And so writing, you know, I just have to be aware, to be more aware of being inclusive and to challenge my own prejudices and all the rest of it. I mean, I said at the big front of my book, one of the best things for me that's happened to me over the last 5 years, something like that, was the notion of anti-racism, which I got really excited about because I think that absolutely fitted with how I've always thought, was that I'd always thought, you know, I've tried, obviously I don't think I'm racist, but clearly I am. I mean, I am because I just am, because it's in there. And so I've always thought you have to know your own biases and you have to bring them out to the fore, and then you have to actively deal with them. And then when I started reading about the notion of anti-racism, I thought that was just perfect, because that enabled me to be reflective, not to be in denial, and to be reflective, and then to actively kind of try and be a better person because of that, really. And I think that's the same for sexism. I've always thought, you know, you can't just be benignly not sexist. Of course you are, because we live in a sexist world, so we have to be anti-sexist. And so I think that as a construct helped me really to kind of think you can look inside, see what's in there, and then do what you need to do to kind of work it out, really. But I think to go around pretending you don't have biases is naive, really, because we've lived in a world which gives you those biases, really.
I think this has like been so powerful, like this conversation, but definitely about honesty, and you know, you're brave enough to do that, meaning like you're able to change, you know, adapt and be open and change it, and you aren't like, I'm not doing this, I'm not interested. You actually went through the exercise and you did it, and you don't feel, you know, you don't feel as if you're doing anything bad. You're being open with yourself, and I think that's important as a person in the discipline.
I mean, my moment, I suppose. I mean, I've got a son who's 23, and I am very much a feminist. And I was, you know, I was brought up in a kind of era where, you know, men were, you know, the problem with men and all of this. So that was very much the discourse, and women were fighting to be equal, and men were difficult, men were this, men were whatever. And I remember going to a health psychology conference with a colleague of mine, and she just had a little girl, and I just had a little boy, and she said, I'm bringing up my little girl to be a feminist. She needs to know how, you know, I think men are bastards or something like that, she said. And I remember saying to her, no, that's my little 3-year-old you're talking about. You can't bring up your 3-year-old to think my 3-year-old is going to be a bastard, because I'm bringing up my 3-year-old boy to be lovely. And I remember thinking then, right, okay, that was a real moment for me, was, you know, I need to see the other side. So as a woman, I have to also see the perspective from men's perspective, because I've actually given birth to one. And that was really important for me, to give birth to a boy who was a fabulous boy in all the ways. But I suddenly saw the other side of feminism. And I remember that being quite a moment of dawning on me, thinking, okay, I've got my own prejudices here and I've got to deal with them. And I've got to sort them out.
It's been, like I said, it's been super helpful, and thanks so much for sharing that. I want to thank you for your time, for being a great guest, and I know that time is sometimes precious. So I think a huge thank you to take part in this podcast. And before I go, listeners, if you want to reach out to Jane, you can do. I'll leave some details in the description below. But I'm going to hand over the microphone to you, Jane, where you might want to share a few words to inspire our current trainees and future trainees, if you like. And once you stop talking, I'll stop recording.
Okay. Gosh, she wants some words of wisdom. I would say just carry on being curious about the world, that we're in a very lucky profession, that we are able to ask questions and meet lots and lots of people, and just carry on being curious about everybody that you meet and the stories that they've got, and who they are. And I also think I would probably say never think that you're finished, or you're the end product, or that you're sorted, or that you know the answer, because you kind of don't. So always being open to being wrong, and take on being wrong or working things out when you've got things wrong. And then you can carry on having some sort of open mind, I suppose, as you go through your profession, whatever it is that you choose to do, whether you're teaching or whether you're researching or whether you're a practitioner. But yeah, stay curious about the world and always be prepared to be wrong and to change your mind about things.